Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis. I'm with Rick and Paul. How are you guys doing today?
Hey, great.
Doing
Thanks,
well.
Dennis.
Yeah.
Perfect. So, the reason why I brought you two training masterminds on the podcast is, I think this is something that happens to me, happens to a lot of medics, I think fairly frequently, is that somebody gives you a call, they write you an email, hey, can you come train my guys? And there can definitely be a lot of confusion, a lot of miscommunication about what they want, how long do you have, kind of all these different problems that come up along the way. So if you wouldn't mind, I think let's talk about that and how we can get this done in a better way.
Sure. Where should we start with that?
Sure. So this is I think a pretty big problem. So let's start off with the ask, right? So somebody calls you and says, "Hey, we want prolonged field care training. We want advanced medical training. My guys are, 100% up for it, and we're deploying or we're leaving here in, a month or some other ridiculous time frame. And we want you to take them from zero to hero."
I think that's almost a best case scenario because a lot of times those people are not getting the time requested. They don't have anybody advocating for the training that they need. So if you get that far, you're in a pretty good place already. It's when you have that team medic who's trying to get his team together. There's no time in the schedule. There's no money. There's no resources. That's when things get really difficult and you have to be really creative. But if you have that command buy-in, you have somebody that's trying to help you out and push you in that direction. That's huge. That's a great starting point.
Yeah. What do you think, Rick?
So, I think the biggest thing you have to look at is how much time you have to train. Look at what level of training that they're starting at, and you don't necessarily get a good assessment from the unit. You have to kind of suss that out. You have to be ready to be flexible when you get there because I can't tell you how many times I've been told, hey, these guys are equivalent to this. And then you show up and they're not. And somebody was being very generous. And looking at how much time you have and then figuring out a starting point and an ending point. What's our goal? What's our objective here? What do we want to get out of this? And the big terms that are thrown around right now: PFC, PCC, LISCO, low signature, all this stuff. A lot of it's not well defined, and people ask for it because it's a buzzword. It's what commanders want, but it's not well defined. They often don't know what that is.
I couldn't agree more, Rick.
Helping them to find that and to set those realistic goals. Hey, man, we got 3 days. Okay, check it out. Here's where we're going to start, and in 3 days, this is where we want to finish. Okay, you can call it whatever you want.
Yeah.
Yeah, I actually have a 12-step guide that I wrote for exactly this. The very first step is decide the goal of the exercise. So it might be an exercise, it might be formative, it might be a mentored learning event, but there's some kind of thing that you're doing. Is it a validation scenario? If you figure out what your goal is first, then you can look at all the other stuff next. What are the learning objectives? What are your criteria for validating? But yeah, the goal and the time frame are huge.
Yeah. Yeah, absolutely. I mean, you can't even begin to have a plan when you don't know the time frame, right? And usually, at least in my experience, the time frames are always crunched. Like, we got 3 days, and we want you to teach them, to be surgeons, right?
Yeah.
Something ridiculous. So immediately, you have to start with some kind of expectation management there. What you're asking is kind of impossible. But I can do this, you know?
Yeah.
So, other than, getting kind of that basic information, what skill level, how long, what resources kind of thing, what else do you want to know?
Yeah, the next thing that I would want to know, if you have your goals and you know what your desired outcome or learning objectives are going to be, the next thing is, are you going to run a scenario at the end of this thing? And how long is that scenario going to be? Is it going to be something where you're trying to replicate your worst case scenario? Or is this something where you just need to fit as many of those learning objectives into a time frame as possible? So there are a couple different ways to do that, where you train to time, or you train to proficiency.
Yep. What do you think, Rick?
No, absolutely. I kind of like combining those. If you have the opportunity, I mean, when you look at adult learning and all of that, having the repetitions is valuable. And then I found that often when we set up these scenarios, these training scenarios, I mean, you can start small. You can start with, hey, we're going to do M in March. This is what we're doing. And you do micro scenarios, micro training. And, okay, we're all going to practice, tourniquets, different parts of the body, putting it on yourself, putting it on somebody else, putting multiple tourniquets, whatever. And you run through that until everybody's, fairly proficient. And then you add something else to it, or you go on to the next thing. And then you have a culminating where it brings it all together. But, you get these reps in, and people start getting proficient and getting comfortable, and then that creates some training scars. I think they get used to the scenario and the pace of what you set up and run. And real life, you don't know what that's going to be like. So you have to do something. I like to do like a little FTX type thing to change the parameters. So here we set a pace every day. We've done, point of injury to here. We've done this. Everybody switch roles. They get comfortable. They're doing the things. And then we throw in multiple patients. We, change things up. We pull assets away. We change things and we make them think, and it kind of takes them out of that comfort zone. And, for a culminating exercise, I think that it helps erase some of those training scars and remove some of that comfort that they developed.
Yeah, I think we're talking about the culminating exercise at the end, and I think that's a great place to start, because you really do have to work backwards if you want your guys to be performing these specific tasks and know this knowledge in these environments. That's where you start, and then you go backwards and you work on the rest of the curriculum from there. And then you can look at, realistically, do I have 3 days? Do I have 2 weeks? What is that going to look like? And then you have to start cutting things out. But knowing what you want, again, you're starting at the goal and working backwards is a great way to do it.
No way. Not that Army backwards planning thing.
That's a stupid NCO thing. But so you mentioned, worst case scenario versus probably like the most common, right?
Yeah, that's another difficult thing to do.
Is there kind of is there value in creating the worst case scenario? Because I think it's almost the kind of the default, at least on the military side. I'm sure everybody else does as well, where you have, worst case scenario, everybody but one person is wounded, and we're just gonna torture this person for, it's prolonged field care, so we have to do it for like 16 hours. Well, just to be sure, we'll do it for 24 hours, and then as the day goes on and we get bored and tired, we'll just walk it backwards. I guess, how far do you take these worst case scenarios? Let's start with that one.
Yeah, what I would do is if this is going to be team training, then they need to see that worst case scenario, and that's going to actually help them make better decisions while they're deployed, is what I've found. If they understand that they could potentially be a patient on a litter for 16 hours and how horrible that is, or even just one of the guys taking care of that person, I think that really does help to prevent some of the dumb stuff that we do when we're deployed. yeah, we do some pretty dumb stuff if you look at some of the AARs. And if you start working from that position forward, then yeah, they do have to see that worst case scenario. What you can do though is you can put in some of the most common stuff, the DNBI, everything else that they're going to be actually experiencing throughout the training and the rest of the week. So I think you have to do a little bit of both, but as your time gets crunched, those little easy layups are probably taken out and you have to focus on that worst case scenario.
Yeah. I mean, how would you go about building that worst case scenario? Is it just like throw the kitchen sink at them, or do you try to be more specific?
Yeah, I think you can give them a little bit of everything. Look at a survivable injury that they're going to potentially be able to take care of, or you give them a non-survivable injury that they have to do some expectant casualty care on. That throws people for a loop as well. Both of those would probably be considered a worst case scenario. And then once you mix those things in during the time frame that they have done planning on, if they said my evacuation is going to no shit be 16 hours, then that's something that I'm going to have to look at.
Yeah. I mean, that's when you look at, setting that, it's kind of understanding what the organization's mission set is, what they're training for, to set up that scenario. What's the worst that realistically we can expect? Because I could dream up some total nightmares, but the likelihood of any of that happening is so minute that we're kind of wasting time training on it, looking at that unit and where they're going, what realistically a very bad day at the office could be for them, and then setting that up and exposing them to that, as opposed to just having them totally overwhelmed and eating that turd sandwich for the next 24 hours and just struggling and not succeeding. There's no way you could succeed. But having it realistic and somewhat reasonable. And on the flip side of that, there's a value in training what they're most likely to come into. And that's kind of what Paul is talking about, the disease, non-battle injury scenarios that you can inject in there. That's probably what they're most likely to encounter, with the worst case being what we hope that they never encounter, but they may. And we want to prep them for that too. So interspersing that DNBI in there is prolonged care. You have lulls, you have boring spots, and to keep them engaged, you have to fill that with something. And real life, it's going to be other things, missions. It's going to be okay, we've got a KLE to do. We've got to go do this. We got to go do that. And hey, I've got to go reinspect the mess hall. I've got to, whatever. You've got other things to do. Yep. But in this training scenario, it's really hard to incorporate those other things. And but yeah, having those injects in there for that most common medical problem that they're going to see is a way of utilizing that time in a positive way.
Yeah. And I think the injects, like, it doesn't have to be anything particularly complicated. It just is something that it's an additional thing to think about. Like, if my main worry is, vehicle rollover, okay, now you have a crushed patient. That's pretty bad.
Yeah.
Like, I don't have to continually inject cholera patients and malaria and like all these other complicated things. Like, you can just be guys with like a bad rolled ankle, and now he can't really carry your litter anymore. How else are you going to handle this situation?
Well, I mean,
I think one of the problems though is when you have, normally what I see is guys get between 2 to 4 days. And so a year, they get 2 to 4 days of dedicated medical training a year. And what are you going to cram into those 2 or 4 days?
Everything.
Trying to fit everything in those 2 to 4 days is impossible. But now you have to look at what is most likely and most dangerous. Like you said, car rollovers, pretty common all over the world, no matter if you're on a JSET or you're traveling. So that's a great place to start. without getting into crazy situations that they may never see. So start with something that's realistic, that's an actual concern of theirs, and then go from there. Because you do need some buy-in from the students. They need to believe this is real and this is something that they could see, or else they might stop paying attention. There's a lot of human factors involved when you're training as well.
Yeah. Yep. All right. So, we've put our heads together, we've come up with the perfect plan that checks the box on every expectation and hope and desire, and it's perfect. Today is training day, and we thought we were going to be training the Yankees, and it turns out that we're training the Chicago Bears instead. Bad news Bears. So whatever, those upper limits of our training that we were hoping to get are looking a little dim. Like how do we adjust fire, in a quasi rapid fashion, because we're burning time.
Yeah, and one of the steps that I have is selecting and briefing cadre. So if you don't have cadre that's available of being that flexible and adjusting on the fly, then you're not going to be able to do that. So if you don't have the best cadre that's the most relevant to those students, then that's not even going to be possible in the first place. But a lot of times you're going to need specific medical specialties, people with experience, people with teaching experience for those instances and those environments, and that's not really easy to find.
No, it is not.
Yeah, we go through a vetting process to try to build our instructor teams that for that reason. I mean, that's one of the big things that we fight with the doctrine developers and with TraDoc about. They want a lesson plan that anybody can pick up and read and teach the lesson. And I'm like, no, that's not. The lesson plan is a guide, an outline, but it's vague for a reason. I think that we need to hire experts that have that experience and knowledge and flexibility to be able to read the room. It's when you're teaching, it's kind of like a performing art. You're reading the room. You have to be able to do that. You have to see, hey, man, I'm putting these guys to sleep. I need to change how I'm doing it. But you need to be able to have those people that can do that have that flexibility, and a lot of that comes with not just experience in performing the tasks, but experience teaching. So we have a whole program to develop our instructors to get them to that level, and while they're developing, we have more senior instructors that kind of back them up and kind of help them along with that.
Yeah, that's not a short process.
No.
So
what you mean, like 2 weeks?
Kind of
2 weeks. They're good,
right? Yeah, that's what the lesson plan says. But so kind of going a little bit deeper in that, like it's not really hard to find people who know stuff. Like that kind of goes with their job title. How do you find people that are good at teaching? And if somebody is not that great at teaching, how do you get them to become a good teacher?
Well, that
is another great question. You have to do a lot of vetting because you have somebody who's really good at clinical patient care, and then they get there and they can lose rapport with the students pretty quickly. I've seen to where the students don't listen to that person. Everything that comes out of their mouth is not true, and they're guessing. I mean, it just goes bad really quick. So you have to have somebody that can relate to the students to the point where what they're saying is relevant and believable.
Yeah. What do you think, Rick?
Yeah, no, I think that absolutely is vital to have that person that can relate and communicate. And I think that the other thing is the person has to want to do this. They have to want to share that knowledge, to impart that experience. There has to be a desire there. If they don't care, it's going to show when they give instruction. They don't care. And if you don't care, why should I care? Why should I invest anything into this training if you don't give a crap as the instructor? So, and vice versa. When I'm an instructor, if I got a student with an attitude, then I'm going to try to change that attitude, because if not, we're not going to meet our goals, and it's going to detract from the
we've
from the
definitely seen where even one bad student, if you can't motivate and bring them into the fold and get them to buy in the class, that can poison the whole class. I know we saw it over and over again in SFMS when we get a prior service guy that was too cool for school. All of a sudden, the whole class is. Conversely, if you have somebody that comes in, willing and eager to learn, they really want to be an 18 Delta. Maybe they were a Bravo or in an Echo before, and that class really follows their leadership. Obviously, it's different when you're not in an initial training environment, but something like that, that makes a big difference. So you have to immediately identify that person and figure out what are their motivations. Why do they want to be here? How can I relate to them better?
Yeah.
No, that's definite. You have to get them to buy in, and sometimes we've all seen that. And if you have that one guy or gal that's the problem one, if you can win them over, usually you've got the class. The class is yours, and you've got the buy-in after that. But it takes getting to know them, maybe being a little open, a little vulnerable, and getting a little personal with them, and pulling them out. And that can be done on the side, but you have to be able to recognize that, and the willingness to do that, and to spend that extra effort to do that, to make this successful. And that comes from that passion of wanting to, feeling that what you're doing has value, and that imparting this is going to make their lives better somehow. To have that passion, and that gives you a willingness to do whatever it takes. And that means self-study. That means learning adult learning models, and figuring out better ways to teach the audience that you're going to have. And kind of, just like we do with the medicine, we spend time learning the medicine and nerding out and deep diving, what this does here, what receptor this works on. Why wouldn't we do that with our profession, which is teaching? It's not just medicine, it's teaching medicine.
Yeah.
If you go in with a sense of humility, you're humble, you have lessons that you've learned the hard way that you want to pass on. Hey, don't make these mistakes that I've made. That's a whole nother way of approaching a class than, hey, I'm the instructor and I'm better than you, so you need to listen to me. I've seen both of those things, and obviously you know which one works better.
Yeah, absolutely. I think just showing, like you said, just having some humility, understanding this is not staged to show your brilliance. You're trying to elevate somebody else so that they can go forward. But being able to connect with them on a more human level versus I'm going to crush your spirit, so you just shut up and don't taint my class because this is my moment.
I will teach you. You will learn by the numbers. You will not laugh. You will not cry.
Yeah, I think with the things that we're teaching these days, we're not as involved with that initial training. I think we're all teaching some version of sustainment training. It's even more difficult because now you have guys showing up every 2 to 4 or 6 years, and you're trying to impart these lessons learned. But I think for us in the positions that we're in right now, being able to collect those lessons learned from other people and impart them on future classes is really valuable. It's something that you don't get in other places. You're not going to get in an online course. You're not going to go to some university and figure out, the best way to do a mass cal in Afghanistan versus Syria versus wherever. So a lot of the times we're taking those lessons learned from our students and then immediately incorporating them into our classes in the next coming weeks. So that's a pretty good thing to do. The other thing that we have to do is really trying to change somebody's habits and the way that they perform or practice medicine. And doing that in 3 or 4 days is really hard. It's almost impossible. And I think that you guys have seen that with your, to where you're almost in a validating, you're doing some teaching, you're doing some sustainment and, refreshing, but for the most part, you're validating. And a lot of that the actual training has to be done at the unit, has to be done before they ever show up. And I don't think that's the case as much as it should be.
Yeah.
Yeah. No.
Or, I mean, I think it does happen on occasion, but I think it's also, we practice the things we're good at, right? So, your patient, let's say it's a combat unit, your patient's been shot in the arm. You put a tourniquet on, you win. All right, let's continue.
Put them on the bird and medical training, check.
Yep.
Moving on.
Yep, exactly.
Now we're getting into that combat
things
training.
We're good at.
Yeah, now we're going to get back to that combat training, the important stuff.
Yeah, exactly. And I mean, obviously, it's incredibly important. But we make little offshoots for the different specialties. But I think we've at least in my experience, we always, when we would set up medical training, it would be always something that like we were pretty good at to begin with.
Yeah. I would hope, but so I don't know that. I mean, I think one of the things that us three right here, we focus on medical training, but, units, when they do combat training, I think that one of the ways ahead is incorporating and seeing medical training as part of combat training, not just medical, but communications. All of that has to be integrated, has to be part of the scenario. And I think that I know it's a different topic, but having that somebody that represents the medical training side of the house at the table when you're designing that combat exercise, to have those injects and have those people who can run that medical scenario, and then they can, but have that be embedded and it's all in one. Your commo's embedded. When you're doing combat training, you're exercising your commo piece, right? So, I don't know how we crack that without having that person at the planning table when you're doing, unit level exercises.
Yeah.
I noticed the things that we've been doing lately. What I do professionally now outside of the military is we bring in teams of guys and not just medics.
Yeah.
So we'll have 2 or 3 medics, but other than that, you have all the other non-medics, the leadership on the team. And I think we're spoiled that way, but it really does, when you get everybody together and you can focus on those team dynamics, the roles and responsibilities, it almost becomes a different exercise. You're doing, more team building and rehearsals for their mission, as opposed to if you get medics, all you get to really do is focus on the medicine, because the medic is so busy doing that medicine. They're not doing combo shots. They're not doing outer security. They're not doing rest plans as much as they should. So once you get the rest of the team involved, you really see the extent of how far you can push medicine, I think.
Oh, yeah. I mean, I think, even just a few days ago, I was doing some training, and, when you're talking about like non-medics, you have, the team sergeant or first sergeant or sergeant major or somebody like that, they're doing what they know to do, right? Okay, organize. Okay, these people are over here. These people are over here. They're doing stuff. How can I get you more stuff? But they don't necessarily know, how do I leverage all of that knowledge and experience on this particular problem? Like they don't know what they don't know. And so, the NCO side, kind of beans and bullets is what we do. Telling them, okay, these are the beans and bullets of this particular field problem. Hey, logistic problem. It's not about getting stuff. It's about getting the right stuff, and when you need it and where you need it and how you forecast ahead, kind of thing. Commo, this is the kind of information that needs to get passed along. These are the people that you need to get in contact with. Just taking the engineers or whomever, like the sky's the limit about how you can leverage their talents and apply them. And I think, being able to do that, you're going to reach a lot more people when they realize, like, I'm not completely lost. I actually do know a lot more than I thought. I thought I was going to have to do, in-depth medical stuff that I have no experience about, but I can fully tackle this aspect and lift the team even higher. I don't know. Does that make any sense?
Absolutely. I've seen where without much training, teams that go into those situations, if you just put them into an exercise, what ends up happening is the team almost segregates. Those who know medicine are doing stuff on the patient, and everybody else kind of stays away and they look for other work. There's not usually a whole lot of other work going on in those situations.
They stay away.
Yeah, that's true. But if you get them all working together on one goal, on taking care of this patient, on evacuating this patient, using those non-medics and the leadership alongside the medic in a harmonious way, it really is a force multiplier when you see that happen. Because when you see the medics struggling by themselves and the whole team doesn't know what to do, it's just hard to watch.
Oh yeah, yeah, and
definitely is.
Those medics get their brain is fried because they're literally making every decision and
trying to lead the team too, because the team leadership steps back so far that they expect, this is a medical situation. The medic should be leading this thing. Meanwhile, they're trying to take care of the patient. They're trying to manage their non-medics who are helping. They're trying to talk to, they literally leave the medics kind of flapping in the wind. And when those teams come together and realize, oh, this is just like any other thing that we do as a team, we just need to do different things. So once that light bulb goes on, you really do see some good stuff.
No, I think that's a huge value in having the team there, the team leadership especially. Having them exercise that portion of it, because you'll see, like, when we have just the medics, we have to remind them, hey man, this might not be your call. Whether you get on the bird with that patient might not be your decision. It may be your leadership's decision, and you're going to have to abide by that and to prepare them for that, to make the pitch, make their recommendation, but also to realize the tactical scenario that may drive a decision that's not necessarily in the patient's best interest.
No, that's a great point, Rick, because you could even go higher than that. What is the operational strategic impact of taking care of a person? If you're in another country practicing medicine without a license and you screw something up, what's that going to look like? I think we've talked about those things before.
We go hours into that with stories.
And that's another podcast in itself right there. But kind of swinging back to what the training topic was. So, the people that we're going to teach, not necessarily at the level as was advertised. Would you just turn and just start focusing on the basics and start building that foundation? And, if we can get to those higher goals, then we can. And if we can't, we can't. I guess, how would you tackle that?
I know what I always do is I always start with those basics. You start them with a simple scenario, get them up, get them moving, and they may screw it up completely. I'm sure you guys see that also. But once that happens and you start moving on, sometimes you can get to the point where they realize now during a PFC how bad their March was, how bad their TCCC was, and now they're paying for all those mistakes you made, where if you don't ever let them get to that point, they may not understand the reason for getting that tourniquet on quickly. Like, oh, now he needs 3 units of blood instead of 1, but I only have 2, and I made that mistake, and now I have to deal with it.
Yeah, we call that choosing your own adventure. So you actually make choices and then have consequences for those choices, but you have to kind of balance that. I think if you have somebody such a train wreck on that initial run, you have to moderate that a little bit, because they're going to be just overwhelmed with failure, that they're not going to learn any lessons. You have to, what I find myself intervening a little more on the initial runs, to keep them on track, to keep them to where they make a few mistakes, but we can learn from this, as opposed to a total dumpster fire that I don't even know where to start, when I pick this apart. And then the subsequent runs, I intervene, I speak less, I inject less, and kind of let them go through. And you have to, that's reading your audience, reading the scenario. You have to kind of see what they can handle. I mean, that's my opinion anyway.
Yeah, I think, so what we did this last time, because I had a sneaking suspicion that they weren't quite as they were advertised. So I said, all right, well, let's just do a march run, and like, it'll become incredibly evident afterwards, right? And so, I just picked a casualty that you essentially could go in a myriad of directions, whether that be easy or hard. And luckily, I've been doing this for quite a while, so I understand how to drive the vital signs to get the response that I would like. And then, we start the lane. And I initially, when I talk to them before the run, I tell them from the outset, like, I am 100% on your side. I'm not going to let you fail. However, I am going to let you hit the bumpers a few times to get the point across that you're probably making a mistake. And, when you start seeing somebody like on that mental struggle bus, that they just can't, either they don't know or they just can't get to that decision, being able to interject and kind of break it down, like, hey, like, you see all that red stuff coming out? Like, that was supposed to be inside. Maybe we should stop that. And
I don't
that
think
kind of
your approach is as comforting as you think it might be, Dennis.
I told them I'm your friend.
Yeah.
And Dennis, I can't believe you don't start with a cheat sheet with vital signs, starting vital signs, 3 minutes, 6 minutes. This is what they are.
Yeah.
You don't have that lined up.
If they did good, it's this. If they did bad, it's this. Yeah, I mean, it's complicated. Like, I understand when people have that. Like, I understand, why they want that, because that would be so much easier if I had a doc tell me, like, hey, this is what they should be. If they did good, then it goes up to this. If they did bad, it goes down to this. But there is a myriad of mistakes that can happen along the way that would completely throw those vital signs out the window.
Yeah.
And I'm not saying I'm perfect at it, but I think just having understanding of physiology, which if you're training, like you ought to have, and understanding, okay, this is what would happen, or at least close to what would happen, and this is also the direction I want him to go. So I'm going to tweak these numbers, and hopefully I'm going to start making it more obvious they should be going in this direction.
Well, plus you have to, you have to simulate that, human carbon-based life form variance that's out there in the wild. You do this, and that's not the response I expected. I pushed this drug, and holy crap, that's no. The textbook said that this should happen, and it didn't. That's part of the training, is dealing with that, because you're going to see that if you do this, if you do this for any length of time, you're going to see that. You're going to have that variance. You're going to have that, oh crap, I pushed 2 milligrams of midazolam and he stopped breathing. Oh crap, he's that guy.
Right.
He's that unicorn that I heard about but hoped I would never see. Crap.
Yeah.
Now let's see, if
or
I'm really
you push,
prepared.
or you push 2 milligrams of Versed and his breathing goes faster.
Yeah, exactly.
So
Yeah.
it says here in the T maps it's supposed to slow down. Like, I don't think, what are you doing? Um, but even if like the scenario that I ran, like it was not in my mind particularly complicated. For the student running it, this was incredibly complicated, and it wasn't because I made the patient crash. It was really in that particular scenario. I knew that the student was not comfortable with his narcotics, and he wasn't comfortable with his dosings, and so I just showed him what hallucinations look like.
Yes.
So and big learning experience there. They didn't have a method to move the patient, so ultimately we just picked him up and put him under our arm and carried him. But again, simple stuff. In a short period of time, I think in that case there was a lot of learning that took place, and hopefully, I'm speaking for myself. Maybe the students, if they're listening to this, they're rolling their eyes and shaking. But because I wasn't berating them, I wasn't calling them stupid or insulting them. I just went along for the ride, and I pointed out simple things that maybe would help. It made them more open to teaching later on, and showed them like, hey, you do have some deficits, but that's okay. We're going to polish these things up, and hopefully you'll be that much better.
Yeah, sometimes getting somebody to that point is as valuable as anything else. If they can realize, oh, wait, I'm not the super medic I thought I was. I do have some of these gaps and deficits. I used to know this stuff, but now I've forgotten. I haven't seen real patients in a while. And then you can work from there. It's really hard if they don't get to that point and they don't have that introspection, that realization themselves. One way to combat that is to get them out seeing real patients. I know we're talking about training and short sustainment iterations, but sometimes going out and seeing a real patient, whether it's on an ambulance, getting into a podiatry or a colonoscopy clinic or something, just working with those drugs, it's gonna pay off huge for you.
Yeah,
definitely.
Even just a clinic, like you're going to the PACU or you're going to pre-op or something like that. You don't even get to see the big show, but there is an enormous amount of IVs that need to get put in place. There's patient monitoring that needs to happen. And so you get to see the aftermath, you get to see the setup. And I think especially when we're doing our MPTs or really any kind of clinical type rotation, we learn the stuff. Like, okay, this is how you use the iStat. This is how you do the procedure. This is how you do the whatever. What we aren't very good at, and I'm going to also blame the docs because I like to blame them.
They get paid more.
But they get paid way more. Probably way too much. But they're also, what I don't get is their clinical decision making. Like, why am I pushing fentanyl versus the 37 other narcotics that you have in this the Pyxis? Why am I getting the iStat? Like, what am I looking for?
How is this affecting my treatment decisions here? How is that weighted? What is this telling me?
Right. Like, why is the central line important?
Yeah. I have guys, I've heard, guys say, well, the EMA, how does the reading on the EMA, how's that going to change your treatment? Like,
a lot.
Okay. It can change it quite a bit. I'm hoping, but it's a device. Can I do without it? Yes. Can I do as well without it? No. And that's kind of when you go through this whole setting up training and all that, looking at their level of training, their competency, the equipment they have, and trying to incorporate that and making it to where, okay, if you use this device, what are you getting out of it? What is this? What information is this getting you? And then at some point, kind of talking about, well, what if it breaks? And how do you get by without that? And you could just like, okay, well, I don't have that information, but what, you got to start thinking of, why do you want that information? What are you trying to get? What's the end thing? And then how can I figure out another way of getting that and making that decision? And it may not be as quick, it may not be as accurate, but still.
Yeah. I think that's one of the things that Doug Powell was and he probably still does it to this day, I would imagine, but he'll take you through there and pre-round on patients before you know any of their labs or imaging or any of that stuff. And you have to make a treatment plan without that. And then later on, when you get it, does it change your treatment plan? So you're doing something clinically.
That's awesome.
Just by looking at the patient, and then you get that stuff. So that's another way to do it. But either way, you should know, because you're not going to have all those fancy things all the time.
Yeah. And that's one good thing it's a good thing and a bad thing about different hospital rotations.
Yeah.
Is you see all the cool stuff, and and if you don't understand why it is what it is, then you start thinking, well, that's what I should be doing. I should be putting central lines in all my patients, not these stupid IVs. And I definitely understand. But if you don't understand the purpose behind it, why is the hospital doing it? Is it because it's actually better, or is it because that's what we've been doing and that's what we just continue to do? Yeah, liability, exactly.
I don't get sued.
Right? Then you can find out, if this is important and it's very useful to me, then you advocate, hey, we should have this equipment, like the ultrasound. This can work for us. We can use it, and I understand how to use it. We should be getting it versus, CT scanner.
I mean, you look at,
they're coming.
You look at hospital rotations, and I think that's one of the huge values of them. They, when we do the rotations, we often miss out on the point of injury care unless there's a paramedic ride along type deal associated with the rotation, which I don't know too many of them that have that right now. For standing medics, in training it's different, but for standing medics, I wish they would bring that back. But I think that one of the best rotations I had was at the Baltimore Shock Trauma, and being part of a surgical team, having the life flights come in and grabbing them off the roof and bringing them down and scrubbing in, and then taking them through surgery, DCR and all that, as a definitely not as a lead. I was hand me this, hand me that. I was the just happy to be allowed in the room, but
right.
Being able to see that and participate in that, and through the recovery and rounding on them in the ICUs, and seeing what those lab values and what they mean and what information, and then talking with the really smart docs and hearing the discussions amongst them as to the relevance of these different things, and being able to learn, and being put on the spot and being called out for being an idiot and all that goes with it. And then you study hard and you learn, and and then you come back and try not to be an idiot again. Of course you are, but you try.
A different kind of idiot.
Yes. Each day, something different, but, I think that having those experiences, when we look at, for our guys, for medicine, I think that we tend to do medicine, imperfectly. We're in a situation where, in a perfect world, this patient would be with a trauma team. However, world's not perfect. We couldn't get them there. They're stuck with me. I've got to do the best I can. So plan A, P in my PACE plan is already, shot. P in my PACE plan is get them to somebody competent, somebody not me, somebody that has all the equipment, all the stuff to deal with them. When we're doing medicine, it's usually not in the best scenario. It's not in the ideal situation. We're trying to make it as good as we can. And I think that when we look at the training, we have to look at that, because when you talk about sustainment training, then you're not talking about maintaining a set of capabilities at 100% indefinitely. That if you look at our critical task list for our medics, there's no way that they can be competent in all those tasks, at any given time, just all the time. I don't know how you would do that. They would do nothing else. And even then, I don't think you could really realistically do that. But they have a familiarity. They were trained in all of these tasks at one point, and they can do it better than somebody that wasn't. And if I can get them to somebody that does this for a living every day, then I should absolutely do that. However, if I can't, I'm going to dust off the reference books, the computer, or whatever. I'm going to reacquaint myself with this procedure, and I'm going to give it my best shot. And that's the best I can do. So when we look at setting up training, it's to kind of hit as many of these marks within reason. And then we have to divide up the other tasks. We have to leave those to somebody else. We have to say, hey, this is what we
that's
can.
What you do.
Yeah.
That's what you do on that CTSSB, is you figure out where you need to teach, what you need to teach. So what can be taught at the unit? What are you going to learn on an MPT? And what can you only learn at the schoolhouse as opposed to anywhere else? So I think making those and being realistic with that, it's really hard when you get a bunch of medics in the room talking about that stuff. You don't always get a consensus. The two of the other things you mentioned is, if you're honest with your leadership, where the risk still lies. If you have a surgical emergency, they're supposed to have a surgeon within 1 hour by Army doctrine. If you can't do it, now you're in your A in your PACE plan, because P was to get them to a surgeon, as they should have. If a commander accepts that risk, that's on them, and usually they will for the things that we're doing, because there's not going to be enough surgeons anywhere.
And all over the world. That doctrine that's just regular Army, regular military doctrine. I mean, that's not necessarily soft, because I mean, we send folks, so far forward and alone, and very much afraid at times, and with no expectation.
That's the commander making that decision, right? That's not the medic saying, I can take care of these patients. It's the commander that's assuming risk. We don't do that on the ground.
The commander, and when you send a unit to a remote area in, pick a spot in the world that doesn't have a 1 hour surgical asset nearby, that, whoever approved that mission is accepting that risk.
Exactly. Yep.
So,
Yep.
The other thing I was going to say while you were talking about the MPT rotations and not riding in ambulances, we have had people 18 Deltas who have moonlit, done, it's called ODE, off time, doing work on their own time, getting paid to do that without an MOU. So they go to their local EMS service, whether it's their county or a private agency, and they get hired on part-time, and they go and they see patients. Now you're getting non-trauma hours. You can turn those into MPT hours and get paid all at the same time. So if you can bring that up to your command.
Yeah, it's a form you fill out, and your commander signs, and it's totally legal, legit. I mean, that's the legal way of doing it. Or you just go do it and don't tell anybody. But
or you just go do it, Not advocating one way or the other.
Yeah.
It's not going to be for everybody, but for those of you that have, if you have a little bit of extra time and you're looking for more money, there's not a whole lot of incentives to be an 18 Delta other than you get some certifications out of it. Other than that, there's a lot of disincentives for you to actually be good at your job. So this might be one that helps you get better at your job, meet those requirements, and be ready for your team to actually perform in an emergency.
But Paul, that's ludicrous, man. I've got these schools to go to. I've got level 2, level 3. I've got ASOT. I've got SODIC. I've got advanced free fall. I've got I don't have time for that. I've got to be a good team guy.
Yep, and then you're going to deploy, and something's going to happen.
Yeah.
It's really that is your choose your own adventure. What are you going to be good at?
Yeah,
exactly.
Yeah.
Cool. Well, we're pushing up on an hour. So, is there anything else that you guys would consider when you get that call of, hey, can you come train my guys?
Yeah, I'll go first. No, you have a pretty good idea after you've been doing this for a while. You know what they need, and they may come to you with a unique training requirement. Usually it's not that unique. Usually you kind of understand where they're going with it, but you need to hit what they need and also give them a little bit of what they want as well. And making that balance is really the mark of a professional organization.
Yeah.
No, definitely. And I would look at so if you can satisfy the need and a bit of the want, you're going to get repeat custom. You're going to get repeat request. The word's going to get out, and they're going to have their people attend your course. And when you build a course, you want to build something that's value added. So if you focus on being value added, finding out what that is, and that changes over time. So if you're running a course that is going to continue iteration after iteration, you have to have a mechanism to gather that feedback from the audience, from the force, and pick out what's relevant now, and as it changes and as it evolves, that new piece of equipment that may be of value or whatever, a new scenario, a new disease process or whatever, and incorporate that and have a mechanism where you can update your lesson plan, your training objectives to accommodate that. And then, so I know we didn't talk anything about the administrative stuff and getting this, like a program of record and making it permanent. And I think that's a whole different conversation. This is like setting up something and making it be of value to the people that you're training.
Yeah. Cool. Well, thank you guys very much. I really appreciate you coming on and getting to chat about this.
Yeah, thanks, Dennis. I appreciate it, Rick.
Thanks. Appreciate it. Good seeing you guys.
You too.
Hey, good seeing you. That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.